Open book.
Can we use a partner, please?
Partner test. Open book. What is this? High school? Oh. Partner's your computer. Yeah. It's a robot partner. Yeah. Nope. Sorry. Unfortunately. Okay, so just a couple things to wind up talking about critical care. So we've talked about all the emergency medicine related stuff. We've talked about, ooh, everybody's got cake. Sorry, I'm getting distracted easily. We talked about what happens sort of in the acute process of, this is a small window of the patient's overall care, right? So where do they go after that? So critically ill patients, you can think about a lot of people who overdose on medications will probably by themselves at least a night in the ICU, depending on how they're doing. And of course, things can get certainly more difficult depending on what types of symptoms they had coming in. So critical illness, usually you're going to define this as some sort of failure of one organ or organ system. So think about like strokes or like Tylenol overdoses, hepatotoxicity, stuff like that. You have to have something that's on the verge of failing or close to failing to usually warrant critical care. And you can have multi-system organ failure too going on, like if you're septic and lots of systems are struggling. Most critically ill patients are going to be on a lot of different medications. That probably goes without saying, but you have lots of titratable drips to keep their blood pressure stable. You have antibiotics, usually pretty broad spectrum. You have pain management. And then you have to consider their home meds. What do you stop? What do you keep going? Can you give them to them? If they're NPO, can you crush them or get liquid form? So those are all things that are considerations. Fluid and electrolyte changes, hemodilution, low albumin are common in critical care patients. So replacement protocols are your friend. Order, if anybody here goes into critical care, order your mag and potassium replacement protocols. And the GI tract may or may not be reliable depending on how much it's getting used. So oral meds, even if they're crushed and put down a G-tube, might not be getting absorbed fully. Other complications, mechanical ventilation can cause decreased venous return, decreased cardiac output, decreased hepatic and renal blood flow. And if you have a patient undergoing therapeutic hypothermia, which we do a fair amount of at our hospital, it will decrease their metabolism. So overall drug processing actually might be a little bit slower than what it would be normally for a patient. Hemodynamics, we talk about MAP, mean arterial pressure. This is usually our target when we're looking at pressor drips. So pressors are usually titrated to a specific MAP. Usually between 70 and 100 is where you see it goal. It's going to depend on the provider and what they decide to do, or maybe if you have a preference for a higher MAP in certain patients or a lower MAP in other patients, possibly like I think of like neurologic patients, maybe ischemic strokes if they're hypotensive. That's unusual, but would be something to consider. Generally, you would want it above 65. Anything above 65 is considered fairly decent perfusion. And then once you're in that 70 to 100 range, you don't really think too much about it. Correlates directly with volume status. So cardiac output correlates with stroke volume and preload and overall volume. So whether they're getting adequate fluid replacement, blood replacement products if they have some sort of a bleed going on, albumin, those types of things, so your colloids versus crystalloids, those all come into play here and will affect hemodynamics. Central venous pressure, I'm not going to talk too much about these things. These are more like advanced cardiology. So if you go into advanced heart failure, you'll work with some of this stuff, but ultimately not really my realm of responsibility, so I'm going to skip some of it. Shock. So we've talked a little bit about shock in different stages. So you've got three types, cardiogenic, septic, and hypovolemic, and generally they're going to have slightly different effects on hemodynamics. So cardiogenic shock is going to lower your overall cardiac index, but your systemic vascular resistance and pulmonary capillary wedge pressure are going to be elevated. So basically think about it as elevated blood pressure, heart's not doing so well, type of a picture. Septic is the opposite of that. It means your source of shock is coming from your systemic inflammation going on. So you've got resistance that's way down, you've got low blood pressure, and your heart's trying to keep up, so it's overworking itself. So again, the flip of cardiogenic shock. Hypovolemic is a little bit of a mixed bag. You usually see both things get decreased. So cardiogenic shock tends to, cardiac index tends to drop, and the systemic, or the wedge pressure tends to drop, but the vascular resistance can actually go up. Your body's mechanism to compensate for low volume is to vasoconstrict if it can. So, of course, you can have combinations of these too, which even makes things more confusing. But generally speaking, when we're talking about management of these types of patients and looking at the drugs we're going to be using, it gets complicated, and you really have to be able to tailor that to the specific type of system you're targeting. So whether you really want to target the vascular system, hopefully like in a septic patient, you can give them fluids or give them pressors that target the peripheral vasculature and don't really have to give anything beta sensitive to cause an increase in inotropic activity. And hopefully, if you can increase the blood pressure, the heart problem will resolve itself. And similar for cardiogenic, if you can give something like a dobutamine or dopamine drip and increase that inotropic effects and kind of do some rate controlling aspect or rate improvement, you can hopefully decrease the blood pressure as well at the same time. So there's a couple different strategies there. All right, volume restoration. We talked about volume a little bit, but just to review, crystalloid solutions, colloid solutions. Colloids are your big things like albumin, head of starch, blood, plasma products are all considered colloid. If somebody is bleeding out right away, you of course want to replace blood, but sometimes it takes a while. Patients may be in for, sometimes we'll see it where they're in for like a standard procedure under electrophysiology or cath lab, and you don't really expect them. So I don't know if type-in screening is standard protocol, but either way, even if they are type-in screening, it's going to take some time for blood bank to get the blood product up there, where they have albumin right there. So they can give a whole bunch of albumin that gives a colloid that restores volume, that can help with the blood loss and help prevent a shock type situation. That's a really common thing they do in the OR if there is a sudden blood loss from whatever reason, for whatever reason, which is definitely a complication of surgeries or invasive procedures, right? Crystalloids can be hung too, so saline can be hung. It's just that colloid will keep things in the vascular system more so, where if you've got some bleeding or third spacing going on, it can help. Crystalloids might contribute to that. They might not help as much at keeping everything in the vascular system. Ultimately, if you have a big bleed, everything's just going to go out anyway. But colloids have a little bit better of a chance of keeping things stable, buying you some time. Okay, so resuscitation, fluid boluses need to monitor and continue to provide support within 6 hours associated with survival improvement. So this is within shock. So somebody goes into septic shock at like a nursing home, let's say. The goal is to get them in and get them fluid hydrated, or hopefully they're getting that at the nursing home, but you never know. Maybe it's more of like an assisted living or minimal cares or something like that. Target goals, again, we talked about MAPS. Urine output is usually a critical care looking goal. Most of these patients have a catheter in, so you can measure their exact urine output, and that gives you a really good real-time picture as to how their kidneys are functioning, where creatinine might be not necessarily reliable in these patients. So urine output can be a nice thing. You can look at their ins and outs and see how much fluid they're getting and how much is leaving their body. And again, vasopressor if fluids aren't working. So we've talked about pressors. Beta receptors are going to be targeting chronotropic activity usually and increasing heart rate as well. So positive inotrope, positive chronotrope. And then alpha receptors are mostly peripheral vasoconstriction. So most pressors have a combination of both types of activities here. Talked about these last fall, but we'll review them here. So this gets really important in critical care, and a lot of times even if you want to go into emergency medicine, you're going to have to start a lot of these in the ED, and then they'll be continued. But usually you don't have to do a ton of, creative titration in the ED. More so that's going to happen with your nurses on the floor. So it's nice from a provider standpoint, from a pharmacist standpoint, because like you guys pick a pressor, I look at it, make sure it looks good, I send it through, and the nurse is really responsible for titrating that and managing that to target that blood pressure. So that's really where you get some really intense nursing care involvement, and that's why a lot of times ICU patients have 1-to-1 nursing ratios so that they can manage these types of complicated scenarios. So phenylephrine is mostly alpha. It's basically a pure alpha agent. It's not used by itself very often because it's more of a synergistic thing. We like to combine it with a little bit of beta activity. So norepinephrine has alpha, alpha-2, and pretty equal beta-1 receptor, and then significantly less beta-2. Epinephrine is going to have much more of everything, which is going to give it more effects on the lungs, which is why we like it during cardiac arrest, because not only does it stimulate the heart, but it can improve both pulmonary vasculature as well, or smooth muscle relaxation, hopefully help breathing, help with mechanical ventilation if you need to. You rarely see people on epi drips long term. I think the mortality goes down significantly if you're on epi in a sustained way. Dobutamine, basically the opposite of phenylephrine. It's pure beta. If you gave a ton of it, you might get some alpha activity, but for the purposes of this class, we'll say it's pure beta. And dopamine has a bit of a different mechanism. It has some beta and alpha activity, but it also hits separate dopamine receptors, which cause sort of a downstream effect. They work in the kidneys, and it also does, at certain doses, will have some cardiac positive inotropic activity. Vasopressin, peripheral vasoconstriction. Doesn't have the same receptor profile and targets specific receptors for vasopressin, and It's a nice synergistic agent. You see the vasopressin added on to a lot of things because it's sympathomimetic to a certain degree, but because it's working on vasopressin receptors, it has a different roundabout mechanism for how it causes vasoconstriction. And milrinone is a second option to dobutamine as a pure positive inotrope. So again, we've talked about this before, but just to review some of it a little bit. All right, so which one do you pick, and is there a better one? Not really. So there's not really any high-quality evidence to recommend one pressor or the other. I think most people are most comfortable with norepinephrine. Dopamine is also a popular first choice if you're looking at more of a cardiogenic shock type picture. I would say norepinephrine is by far the one. Like if I know somebody's coming in and it's cardiac arrest situation, or I know that's like a really maybe a severely septic patient or something like that, I always have a norepinephrine drip ready because that's always the first one we're going to go to. Unless it's a pure cardiogenic shock, then we might start dopamine or dobutamine right away. But norepinephrine is just it's the most versatile of the bunch, and it's easy to titrate. It's short acting. It just works very well, and most nurses are very familiar with how to use it. You can get situations where multiple pressors are used together, so it's not a great situation, but it's not uncommon to see 2 or 3 pressors on board with an ICU patient. For a severely septic patient, that's pretty common to see norepi, vasopressin, and phenylephrine. That's a pretty common trio that's used. I think of vasopressin and phenylephrine as being the 2 adjuncts I would go to first after norepinephrine is started. And then again, the beta dopamine or dobutamine would be more so for those cardiogenic pictures. So they're a little bit more narrow in their scope as far as what they're used to treat, whereas these are just broad pressors that'll work for pretty much any type of vascular resistance issue, which is going to be probably the most common form of shock you'll see. These are hard on the vasculature peripherally, so if you are working in an area where, like in the ED, for example, sometimes we don't have an option. So I do get this question from my providers and nurses, can I give this peripherally? How long can I do it for? You can give it through peripheral vein pressors. It's just not recommended, and there is no real time frame. The idea is you want to get them medication when you can, but ultimately get them into the central line as fast as possible. So you might have to do a procedure, get them their central line, but you can run it through there. I mean, I've seen it done for a few hours. Usually there's not major complications, but certainly get that central access as soon as you can. Dosing is going to vary. You'll see people ask doses, and I'll be like, well, it's 10 to 15 we could start at. And they're like, what do you mean? I'm like, well, mic per kilo per minute, or mic per kilogram per hour, or milliliter per minute. It depends on the institution, and most of them have different units in their system. I think mic per kilo per minute is pretty standard for almost all titratable drips. Like propofol is dosed in mic per kilo per minute. Most pressors are dosed that way too. But you might see things that are a little bit different too, and don't be too surprised on that. The nice thing is that infusion pumps are programmed with all this stuff in them. So the nurse really just has to look at it, make sure it matches what's in the order. They don't have to think too hard about, okay, am I matching my units? Do I have to convert from mic per kilo per minute on the electronic medical record and then figure out what mil per minute? No, that all does that for you. Put in the weight and it figures it out for you on the chart based on the volume of the product you're infusing. So it's pretty straightforward. It looks confusing, and it kind of is if you're trying to do the math in your head during a quote or something, but for the most part, it's pretty standard dosing, and it's all programmed into all of our electronic systems. Generally speaking, the higher the dose you give of a pressor, the more alpha activity you're going to get. So here's an example of dopamine, which is kind of interesting. At really low doses, dopamine really just hits the dopamine receptors in the kidneys, which causes an increase in mesenteric blood flow, and will help the kidneys process fluid a little bit faster. So almost like a forced diuresis of sorts. Once you get up to the 5 to 10, you still get some of that activity and blood flow increase to the kidneys, but you also get beta activity. So that's why dopamine at most doses is pretty much an inotrope. It doesn't really get that alpha activity and that actual pressor activity until you push the dose higher. And once you push the dose higher, some people will say you do kind of lose the beta activity. So it's interesting. If you want the dopamine to have a cardiogenic effect, you want to keep it within this range. Don't push it higher. It's not like you're going to get more cardio effect. You kind of cap out at a certain point, then you just get alpha activity after that. Again, a little bit advanced, but something to think about. I'm not going to test you on dopamine ranges or anything like that. I think it's just important to know that your infusion rate does affect the receptors it targets. And that's similar for a lot of the drugs. So norepinephrine is pretty equal, but at lower doses you do get some more beta and less alpha, and at the higher doses you get more of the alpha activity. Considering pure inotropes, so when do you actually use like a milrinone or a dobutamine? if low cardiac output after fluid resuscitation, that's when you'd consider it. So, I mean, if you have a heart failure patient who comes in a critical situation, that's a giveaway. You're probably going to use something like that. But fluid resuscitation is always the first thing you want to try. Try and rule out anything else, and then you could go to inotrope after that, as long as the pressures are looking pretty good. Okay, so talking about sepsis. Sepsis has, talked about this last fall, but I think sepsis is important. It's a pretty high mortality and very common presentation to the hospital. I'd say I see, I don't know, close to, wouldn't be out of the realm of possibility for me to see a dozen sepsis patients in a shift in the ER. It's very common. So broad spectrum IV agents started ASAP. Data shows pretty consistently the sooner you start antibiotics, the better the mortality benefits. So we have a big program around this that if you meet certain criteria, you get broad spectrum antibiotics pretty quickly. Now, the debate sometimes comes into play of what do you know about the patient, and can you narrow therapy right off the bat? You always have to go really broad. Like, let's say you have a relatively healthy person who comes in with a pretty obvious pneumonia that you can diagnose via symptoms and also X-ray or chest X-ray or whatever you've got, and you want to just do ceftriaxone and azithromycin. Is that wrong? Even though they're septic, maybe they've got a high lactate, their blood pressure's wrong? No, I don't think so. And actually, we do that sometimes. If the patient has zero criteria for anything else, it's really the broad spectrum is when you're kind of wishy-washy between infectious sources. So a lot of times it'll be like, well, it could be pulmonary, it could be belly, I don't really know exactly what we're looking at. Or maybe they have a history of recent hospitalization or immunocompromised state. They're an oncology patient or a transplant patient. That's where for sure you'd want to go more broad spectrum. But if you have somebody who doesn't have much medical history and otherwise pretty healthy, but just happens to have a really bad pneumonia or something going on, it's not wrong to pick something that targets those organisms, because really that person doesn't have any MRSA risk, doesn't have any Pseudomonas risk. So what's the point of doing broad spectrum? So that is possible. So you don't always have to go broad, but if you aren't going to go broad, if you're going to go narrow on a septic patient with antibiotics, really make sure you've got all your bases covered and you double check, making sure you haven't missed anything. Make sure these are continued. So if you are on the other side of the hospitalization, whether you're working as maybe a PA as a hospitalist type role or in an intensivist type role, just make sure that you know when the patient got the doses in the ED and when they were, if they were discontinued or not. So most ED practice works as one-time order. So you put in a one-time dose, and then whoever admits the patient to the hospital is responsible for the continuing doses. So in our hospital, like, we have a report that we run daily to make sure this doesn't get through. And every once in a while, you do see this happen where somebody got something and no one addressed it, and they've been a whole day without an antibiotic. And the admitting hospitalist thought that it was already ordered, and the ED person was like, no, I just did the one-time dose. And so ultimately, you end up with somebody who's missed antibiotics for a whole day, and that's definitely not good. So again, just a word of warning: make sure that you're double checking when they got their doses last, and looking at when you need to be ordering something, especially if you're on that admitting patient side in the hospital. Control your infection source. So of course, this is not my realm of expertise, but that's important for sepsis management, obviously. De-escalation if appropriate. So once you get your culture data back, clinical picture improving, I would say de-escalate. We take off vancomycin really fast on patients. If you get a negative blood cultures, or if their blood culture is growing something that's not Staph aureus, we're going to get rid of it right away. So it's not uncommon for a patient to get like 1 or 2 days of vanco and be done. It's just data shows that that's more important to do that than possibly risk the resistance. And I don't think there's a huge risk of getting resistance with vanco after only a couple of doses. It's probably not a big deal. So better to be safe than sorry in that standpoint. 7 to 10 days of antimicrobial therapy is usually adequate to resolve most standard sepsis-causing infections. So if it's bacteremia, pneumonia, urosepsis, whatever it may be, that could usually resolve within that time frame. Discontinue antimicrobials if no infectious source. Sometimes people come in and look septic and they just aren't. Something else is causing it, and certainly you can narrow down that with cultures and other things like that. Infectious disease consults, definitely use your infectious disease people if you're at all concerned about your septic patient. Okay, glucocorticoids may be beneficial if the patient has severe septic shock with systolic blood pressure less than 90 and they aren't responding to fluids or pressors. So glucocorticoids are kind of a last-ditch effort to help improve hemodynamics in these patients. There's not a lot of good data supporting this, and it can really mess up other things too. So as far as side effects go, high-dose steroids, you can mess can cause blood sugars to be out of whack, cause the patient to increase delirium, and agitation can be seen as well. You can check somebody's cortisol response by doing a plasma cortisol and a ACTH stimulation test. I think we talked about this last fall a little bit. But basically, you stimulate, you give the synthetic ACTH, or cosentropin is the name of the drug, and it will cause a forced release of cortisol, and then you measure cortisol levels after that. And if the patient's producing cortisol, you can measure those. If not, you won't see anything. So usually you try and do this before you'd start glucocorticoids, but if you already started hydrocortisone, it's not going to be reliable, and then your labs are going to get interfered with. Hydrocortisone is usually the drug of choice. Remember, that's basically synthetic cortisol. It's our drug version of our endogenous steroid hormone. And again, last-ditch effort. This is something that isn't done routinely at all. So you really have to be at the end of your rope with pressors and fluid response to try this. Pain management is very important in critically ill patients. Patients probably aren't going to be able to express pain normally, so there's a lot of behavioral-related pain scales, especially if you think of somebody who's sedated and intubated. How do you assess their pain? You can't ask them 1 to 10 type questions. So I'll show you an example of that here in a second. But treat the pain first. So if somebody is in some form of pain, you want to make sure you're titrating their usually opioid narcotic to an appropriate point so that whatever pain scale you're using is showing that the person's pain is resolved, or at least to an appropriate level. And then you would add sedation on top of that. So the reason I'm pointing that out is because you put somebody on a bunch of opioids that's going to sedate them already, so you might not need a whole lot of sedation on top of that. So when we're talking about managing sedation with propofol or anything else that's non-opioid, you just got to consider what else you've got going on. So that's where I'm getting at with that. You can certainly use other drugs in addition to opioids, like acetaminophen and NSAIDs make for good synergy depending on if the patient doesn't have any contraindications. And then we want to keep titrating and doing continuous infusions, staying on top of the pain, whatever we need to do to make sure we're keeping the pain scales appropriate. This is an example of a behavioral pain scale. So facial expressions, movement, depend on coughing but tolerating ventilation, fighting ventilator. Those are types of things that are more or less signs of pain. Now, if somebody's paralyzed, that's very difficult to assess their pain. So in that case, usually they're on a fentanyl drip to compensate for that as part of their sedative regimen. Okay, so opioids may be enough depending on how much opioid the person is getting. And then on top of that, you can add propofol and dexmedetomidine are the 2 most common sedatives that we're going to be using in addition to our narcotics. Benzodiazepines have really fallen out of favor. So midazolam drips were really popular for a while, and we still use them occasionally. They have some good utility. If you had like a patient with prolonged seizures, or sometimes alcohol withdrawal patients will respond well to that because it'll prevent withdrawal seizures. But that's pretty much it. Benzos are highly associated with increased delirium and prolonged ICU length of stay and prolonged mechanical ventilation, which is all bad for the patient. It's expensive. An extra day in the ICU is tens of thousands of dollars. So these drugs, propofol, dexmedetomidine, and opioids generally aren't as heavily associated with that. Benzodiazepines seem to be kind of the smoking gun when it comes to ICU-related delirium. So that's the first thing we look for if somebody's getting delirious, or look for switching them off of them. All right, propofol. So propofol is great for conscious sedations in short term. It's also a good continuous infusion. It's got fast onset. It's pretty easy to titrate. However, the longer you use propofol, it's very lipophilic, the more it distributes out into extra body tissues. So if somebody's been on propofol infusion for a couple of days, it might not titrate down as fast as you think it would. So if you give somebody a shot of, or a dose of it for conscious sedation, you're looking at a few minutes before they wake up. If they've been on it for a few days, you might titrate down or stop the drip, and it might be an hour before they wake up. So you will see that multi-phase kinetic distribution model come into play, but really only for sustained infusions and also high-dose infusions. If the dose is relatively low, you might not see anything like that. Loading dose may cause hypotension, and high doses may cause sustained hypotension, so just be aware of that. Generally, I don't think I've ever, I should say never, but I've never seen a really significant drop in blood pressure from giving somebody a dose of propofol. Sure, it could happen if you gave them a ton, but usually it's transient. You just see a transient bump down. It's not something we really get too excited about. Every once in a while, you do see a more significant drop, but it's pretty rare, actually. Propofol has no analgesic activity, so remember that's why fentanyl or Dilaudid or whatever opioid you're going to choose works well in synergy for that, to provide that aspect of care. It does have caloric content, so we'll talk about parenteral nutrition here, but it's 1 kcal per mil. So if somebody is on propofol infusion, we do factor that in when we're dosing their parenteral nutrition. Propofol infusion syndrome is a really rare thing that I've never seen happen. Really high doses for extended periods of time are associated with this. Essentially, it's a rare mitochondrial metabolic interference. It causes metabolic acidosis and can put somebody into cardiac arrest. It's highly fatal, but again, it's not seen very often. So the point is, with propofol, don't be scared of that. It's not really a big deal. But if you did have somebody flipping along at a really high amount of propofol, you might want to consider some sort of synergy, drop their propofol down, maybe switch them to dexmedetomidine, or up their opioid dose and try and balance that out so they're not getting too high. Dexmedetomidine, fast onset, duration's a little bit longer, so it's not as easy to titrate as propofol. So you turn it down, it's going to take a little bit of time to come off, but it's not as powerful of a sedative. So most people on dexmedetomidine, you can actually wake them up while they're on the drip if you agitate them enough. Not necessarily like agitate them, but you know what I mean. Outcomes are a lot better than benzodiazepines. This has become a really popular drug in our ICU. We use tons of it. It's probably our go-to sedation for continuous sedation for most patients now. Propofol is still pretty popular, but this is definitely a well-utilized tool here. So how do you titrate sedatives? And if you're going to order a sedative drip, what are you looking at targeting? Usually the Richmond Agitation and Sedation Scale, or RASS, is the common tool that is used. And it ranges from +4, which is comatose. This is like a really violent, agitated patient, and then to -5, which is basically like cardiac arrest, borderline. So obviously we don't want the extremes, but usually what you're targeting is like a 2 to a 4. It's pretty common for sedation, depending on what you want, or how sedated you think you need the patient to be. But if somebody's mechanically ventilated, 2 to 4 is usually enough. 3 is probably the perfect amount of sedation for a mechanically ventilated patient. So a lot of times they're targeting 3. So if you order and you say target a RASS score of 3 to 4, your nurse is going to use some sort of a scoring flow sheet. And I just put this on here. I'm not going to test you on RASS scores or anything like that, but knowing how a nurse would go through this, because you'd be the ones ordering it. So then what actually happens on the nursing side? They would score them based on a number of criteria, give them points, and then they could figure out how they would dose it off there. The CAM ICU is also used for delirium assessment. And this is just a way that I put this on here just to show you, because delirium is a big part of ICU management and something that is a huge increase of length of stay, and outcomes are poorer with delirium. So how do nurses assess delirium? This was a study that went on a while ago, so it's about 10 years old now, but anyway, it showed them how nurses were assessing delirium, and so it was interesting to see what different things we're using, and almost no one was getting psychiatry involved. They were mostly looking at ability to follow commands or agitation-related events, as opposed to a lot of pieces weren't even using scoring systems. So there are a number of areas of improvement there. We'll leave it at that. I think it's gotten better, hopefully, in the last 10 years, but it's been a bigger focus in recent years than it was previously. Okay, so if somebody's delirious, it's again associated with increased mortality and ICU length of stay. Antipsychotics are pretty much the drugs of choice for delirium management. We want to stop the offending agent or decrease whatever agent is offending. Benzodiazepines, again, being the big ones, anticholinergics being kind of the second thing to look for. Opioids are plus minus. I tend to think that there's mixed evidence for whether opioids cause a lot of delirium. I think if you've got pain on board and you're managing the pain correctly, I don't think the opioid would. I think actually having too much pain probably would exacerbate the delirium versus controlling it with an opioid. But again, the evidence is a little sketchy on that. But I would say these two are going to be the big ones. Haloperidol can be used. It does prolong QTC interval. It's highly sedating. It hasn't been proved to reduce duration of delirium. It just simply manages the symptoms. So it buys you some time to get your patient under control with adjusting their medications as needed or figuring out what the cause of the delirium is. Second generation antipsychotics seem to be better, showing better evidence. They don't have the same cardiac effects, which is helpful in a lot of patient populations. You're usually using them short term too, so a drug like olanzapine, you aren't using it long enough to see like the metabolic side effects it has. So for a delirium patient, for a few days use, it's actually a pretty safe medication to try. All right, therapeutic paralysis. So therapeutic paralysis, mostly useful for patients who have induced therapeutic hypothermia due to cardiac arrest. So post return of circulation, if the patient's not responsive, it can preserve brain activity if you cool somebody for a while and then kind of bring them back up to normal temperature after about a day. The other times you might paralyze somebody continuously would be somebody who's really struggling with ventilation. So they're intubated, they're really hypoxic despite, placement of the tube is fine, sedation's good, analgesia seems good, no obvious answer there. That's a common thing where they might paralyze somebody continuously just to try and get them under control so that they don't get hypoxic. Control severe intracranial hypertension with neurologic injury. You might see paralysis done for that too. That'd be rare, but it is done. So anyway, analgesia and sedation should be managed first, unless you're, again, doing therapeutic hypothermia, which is protocol for post-arrest. If you're looking at these two things, you want to try and get your analgesia and sedation good before you would do anything else. You have to have that sedative continuously infusing on top of it, just like we would for RSI, sedative first, then paralytic. You want to use the same mentality here. Increases the risk of a lot of adverse effects to paralyze somebody continuously, so it masks seizure activity. So you might need EEG monitoring, especially if there's some sort of neurologic injury. Neuromyopathy is something that's seen. Insufficient analgesia and sedation. It's very difficult. Like we showed that score there. That's okay if the patient's not paralyzed, even if they're sedated. You can usually assess based on that. If they're paralyzed, they can't really show a whole lot of anything when it comes to pain management. Increased risk of VTE, skin breakdown, and corneal abrasions. These can be worked around and managed. You can put ointment on the eyes to prevent that. You can make sure that the patient's nursing cares are up to par as far as VTE risk, and we can do some mechanical things there, and nursing care to prevent skin breakdown, repositioning in the bed, and things like that. When properly managed, you shouldn't really see any of this stuff, but the seizure activity and the analgesia would be challenging, regardless of how well you're managing the patient. Therapeutic hypothermia, so post-cardiac arrest, 32 to 36 degrees Celsius is your target for 24 hours, and then you gradually rewarm at 0.25 degrees Celsius per hour. It does reduce the risk of neurologic injury. There's pretty good studies out there on it. They use a lot of different things to cool people. You can start with just like kind of ice packs in the armpits and the groin. What they do a lot of times is use this cooling catheter, which is just this tube that goes in this artery here. I don't know what is femoral artery. I don't know. Maybe I'm making that up. But anyway, it pumps cold water in there and actually has a temperature probe on it. It will automatically adjust the cool temperature of the water depending on how the patient's responding. So it measures core temperature and adjusts itself. And of course, it's not infusing water. It's just a tube with a dead end to it. So it's pretty cool technology. Simple technology, but it works quite well. All right. So talking about some preventative things in the ICU, because it's pretty much the other side of it. So we talked about some of the acute management. Managing blood sugar is challenging, and a lot of times people will be either managed too aggressively and then they get hypoglycemic, and that can contribute to other issues. So there have been some studies looking at, do you try and tightly control somebody's blood glucose, or do you let it ride maybe a little bit higher if you need to? And there was a study in 2001 that showed that there were improved mortality benefits with 80 to 110 target blood glucose. No one could duplicate those results. And in fact, all the other studies that tried to showed that the mortality benefit actually decreased, or the mortality increased, with tight blood sugar control because people are getting hypoglycemic episodes frequently. So the current standard of care is that you target like a blood glucose that's below 180 but not hypoglycemic. So that gives you a little bit more room to work with. I haven't seen any increased mortality with that. So in case you get that comes up ever, tight blood sugar goals are not necessarily better. Use an insulin infusion protocol. We have a lot of protocols that we built. Talked about that a little bit with emergency medicine and how nurses do that. A lot of it's nursing run now, which makes it convenient for everyone. It's pretty straightforward. Put in the sugar, put in the lab. It tells you how to infuse the insulin, what rate to go at, when to recheck blood sugar. It's really slick. And actually, the new tool we use has, I think we've had almost no hypoglycemia on it. When it's followed correctly, it's very effective. Stress ulcer prophylaxis. So definitely a big complication with ICU patients. One, mechanical ventilation. Two, coagulopathy. So a lot of these patients are on heparin or they're on aspirin at home or whatever it may be. They're probably doing something that increases their propensity to bleed, and mechanical ventilation is associated with that on its own. Some other things that are risk factors down here. So how do you prevent that? IV H2 blockers work great. There's a lot of good evidence that supports them. They're cheap and they're effective. And they work quite well PO too. So if the patient's gut's working, definitely give them orally. But IV is available for people who are NPO or not tolerating oral for whatever reason. There's been some studies on PPIs. It's limited evidence. They likely would work just fine or probably maybe even better. I don't know. There's no evidence to say they're better than H2 blockers. They're expensive when given parenterally, so we don't use them over an H2 blocker unless you'd have a really good indication like a GI bleed or something. That's different. It's obviously not prophylaxis. So stop therapy when risk factors are no longer present. That's a big thing. So if you work in ICU or any type of hospital care, or even if you're in outpatient, if somebody you know or a patient you have just discharged from a hospital and they come in and they've got this new continued medication for PPI, make sure you're double checking whether they actually have an indication for that. That happens a lot where people get on these prophylactic strategies, H2 blocker or PPI, and then they go outpatient and they still have it. No one ever discontinued it, even though the person doesn't actually need it anymore. And then they just keep taking it and then they get C. diff. So try and keep an eye on those things. Antacids are not shown to be effective for this, as you probably could have guessed. Yeah.
Why are they at increased risk for stress ulcers? Is it because they're not eating, or is it just
usually it's both. I don't know why mechanical ventilation is. If it has something to do with the mechanism of the ventilator, putting pressure, and also not using the GI tract if they're NPO, that's definitely a risk as well. Pulmonary embolism, DVT, high risk factor for critically ill due to immobilization. Post-major surgery procedure, elderly patients, obese, if they have history, septic patients, heart failure. It's pretty much your general group of ICU patients right there in a nutshell. Non-pharmacologic options, you can use these mechanical compression boots, kind of like this, like a giant plastic boot, and it kind of compresses in waves, and that keeps the blood moving. It's pretty effective, actually, as a prophylactic measure. And it's usually a good option for patients if pharmacologic options are contraindicated, or if they have a low ICU stay but they're still immobile, you could consider using them. Otherwise, we have drugs. Subcutaneous heparin, dose 5,000 units, Q12 or Q8 hours is the most common one. It's cheap, it works well. That's our standard one we use for prophylaxis. You could use low molecular weight heparin too, either twice a day or once daily. A lot more expensive than heparin. That's the only reason we don't do it. It's not like there's any efficacy difference there. It's just if somebody was outpatient or having an issue with getting their doses regularly, Q24 hours is handy. But if you're in the ICU, there's no reason why you would really care about that. You have 24-hour nursing care, 1-to-1 patient ratio. They can get the doses in 3 times a day. It's no problem. IV heparin continuous infusion can be used. Actually, you can do a prophylactic infusion. It's just a lower infusion rate than you'd give for like therapeutic DVT treatment. And then, of course, patients might be on anticoagulation for another reason. They might have come in on warfarin or whatever new anticoagulant they're on, and that's fine. You just keep that going. You don't need to add anything onto that. Nosocomial infections and ventilator-associated pneumonia are another complication. So good hand hygiene is always important for controlling this. Strongly associated with poor hand hygiene is strongly associated with increased nosocomial infections. VAP is a couple risk factors we'll go through. Minimize vent duration. Assess daily for vent, meaning elevating the head of the bed can help. Just think about ventilator. It's a tube going into your body. Bugs can get on it and crawl in and get into your lungs. It's basically just a mechanical process there. So if you can elevate the head of the bed, it's actually been shown that you don't get as much probably exposure to potential pathogens. Daily oral antiseptic care, chlorhexidine rinses in the mouth can help prevent things from getting down the vent tube into the lungs. GI motility also, good GI motility is associated with better outcomes. So people who have poor gastric activity or for whatever reason not, maybe they have a GI issue, whatever's going on, they are at higher risk for VAP. So other things, limit antibiotics, PPIs to avoid C. diff, so that would be that side of things, but at the same time, your patient might be septic, they might have ventilator-associated pneumonia, you have to treat them with antibiotics, so ultimately you're going to take the antibiotics or not, but just if you don't have to, or if you can stop an antibiotic, you might want to consider it just to avoid the unnecessary C. diff risk. And of course, exposing patients to unnecessary pathogens via having sick people in the room or making sure people are wearing masks or whatever you need to do. Okay, nutrition support, usually managed by pharmacy and or dietary. Sometimes it's a combination effort. Sometimes dietary does it all. Sometimes pharmacy does it all. At our hospital, pharmacy does it all pretty much, but we kind of get a curbside from our dietitian friends. So like we have a pharmacy to dose consult for TPN. So if you wanted somebody on parenteral nutrition, you'd order that and then the pharmacist would take care of it. Enteral nutrition is always preferred. GI tracts, if it works, use it, is the rule of thumb. It's less money, it's improved healing, reduced risk for complications. Tube feedings may interfere with medication absorption. That's the one thing if you have somebody on a tube feeding versus like actually eating meals. So in that case, you can time the drugs around it. A lot of drugs, it doesn't matter. Some it does. So just ask your pharmacist, I would say, if you're in that situation. There should be a pharmacist in the hospital that can go through that with you if you're curious. But a lot of times we just time it out outside of the tube feedings. So TPN stands for total parenteral nutrition. Some people just call it PN or parenteral nutrition. And it depends, and a lot of places will vary, but if you read some of the studies out there, if you're considered intolerant of enteral nutrition for 7 days or you don't seem to be getting enough caloric intake, that's when you'd switch to TPN. A lot of times that happens a lot earlier than that, not the full 7 days. There has been studies looking at, do you start TPN right away once you get some PO intolerance or enteral nutrition intolerance, or do you go to late start always? And the late start studies were shown to have lower overall ICU stays than starting TPN on somebody right away. So TPN has some issues with it. If you aren't using the GI tract, you can be kind of hard on the way your body processes the nutrition. So your liver, kidneys can get worked over a little bit from the TPN. They're working overtime on it versus enteral nutrition processes things a little bit better. Formulas are complicated, so I'm not going to test you on these, but I'm going to talk about them because I think it's important if you ever order one to know what you're ordering. So TPN components are dextrose, amino acids, electrolytes, vitamins, trace elements, and lipids are usually given separate but in conjunction with the TPN. So people joke it's steak in a bag. It's a little different than that, but yeah, essentially it's a meal in a bag. It looks yellow like this because multivitamins are yellow, and so that's why you'll see TPNs look yellow often. If we are out of multivitamins or the patient's not getting IV multivites, it'll just be a clear bag of fluid. Okay, so there are a number of different ways to do this. This is sort of the standard way we would do a TPN in our hospital. So first of all, you want to figure out your total daily caloric needs. Again, there's a lot of equations out there that calculate this differently. So some do variations based on body mass index. Whether the patient's mechanically ventilated, they're on dialysis, pregnant, if they're paraplegic or quad, those could all have different effects on how you calculate it. They also might have stress factors included. So they might have a multiplying factor or dividing factor based on acute kidney injury, cancer patients, septic patients. But this is basically the normal equation. So you're looking at mostly a weight and height-based equation and then an age-based equation. And then if you have a stress factor on top of that. So like, for example, we might have a cancer patient, we might multiply the end result by 1.2 or 1.1 or something like that, just to give them a little bit extra caloric need, depending on if they're cachectic or malnourished coming into the hospital. Protein goal. So the first thing we do is calculate our protein, and this is going to be part of our daily calories. So we want to figure out how much protein is making that up. And generally, your target protein is 1 to 2 grams per kilogram per day. Again, weight-based. Depends on a lot of factors, usually lower for hepatic failure. Your liver is processing the protein, so again, that's what can be hard on patients' liver over time with TPN. Acute kidney injury, because your kidneys are processing some of the protein metabolic products as well, that can be problematic if somebody's kidneys aren't functioning well, so that's why that is a lower thing. If somebody's obese, or or on continuous renal replacement therapy, we usually go more protein. So anyway, 1 to 2 kilograms per day, that's going to give us essentially what amount of protein we should do. Then we're looking at how to give somebody how much lipids the person should get. So we have a lipid emulsion made of soybean oil and egg yolk. And the lipids is going to be about 25 to 30% of total daily calories, and it's 2 kcals per ml. So going through all this to show you that you get your protein, you figure out how many calories that is, you add in your fats, And then finally, you take your carbs, aka your dextrose, and that makes up the remainder. It's usually going to be about 3 to 4 grams per kilogram per day, but it could depend on how much protein and how much lipids the person's getting as well. That's usually where it falls into with the total daily caloric needs based on that calculation.